Welcome, everyone. My name is Mariana Rico. I'm the Medical Director from America's Health Foundation, and I will be moderating our conversation today. Before we begin, I would like to mention that we have simultaneous interpretation available to English and Portuguese. You can select the Spanish of the language of your choice at the bottom icon that says interpretation. Okay, on behalf of AHF, I would like to welcome you and welcome everyone who is here with us today to talk about this important topic. Antimicrobial resistance currently represents one of the most important scientific and economic challenges and health challenges for Latin America. And no doubt it requires innovative solutions and efforts that are coordinated in multiple sectors. This silent epidemic has systemic problems, and if we do not properly take this on, it will be a substantial threat for our patients, families, and our communities, especially in countries of middle and low income, because of these infections that will not be able to be treated. Last year in AHF, with the sponsorship of MCD, we carried along a task force with different opinion leaders with the purpose of taking on this topic to give continuation to this project and be able to share some of the results of the report that was published. We invited you today and our Latin American key opinion leaders in infectology and public health to continue the conversation about the strategies to mitigate the impact of the resistance to antimicrobials and increase the access to treatments against resistant pathogens. You can find the link to download the full report in the chat of the event. I would like to thank you beforehand to all the different panelists. We will get to know each and every one of them for their effort and time for this session, and to our sponsor, MCD, who not only sponsor this project, but are also involved in many initiatives to combat antimicrobial resistance at a global level. Also, I would like to remind you that after the presentations, we will have a space for questions with the panelists. Therefore, I invite you to send us any question that you might have through the chat box. Very well. So to begin our session, I would like to welcome Dr. Maria Luisa Avila, who is here with us from Costa Rica. She will give us an introduction and a little bit of context about why it is important to give a priority look on this topic. Dr. Avila is the ex-Ministry of Health from Costa Rica, and currently she's the head of the infectology department at the National Hospital of Children in San Juan, Costa Rica. She is a pediatrics professor and director of a master's program in pediatric infectology at the University of Costa Rica. Dr. Avila, the floor is yours. Good morning. First of all, thank you very much for the invitation and kind greetings for everyone. It is a pleasure to be here and share with such wonderful colleagues. Thank you so much. If you like, you can show my presentation. Thank you. Very well. As Mariana was mentioning, I will be giving you an introduction of what antimicrobial resistance, especially trying to emphasize in Latin America. Next, please. These are my disclosures. Next, please. And what we're going to focus the presentation is in some questions that seem important to answer and that most likely we have all asked ourselves. What is the relevance of the threat of the antimicrobial resistance in our region, and how does it impact public health? What consequences does it have for our health systems? What is the role of innovative antimicrobials in supporting the stewardship programs and the adequate treatment of resistant infections in our patients, and if patients in the region have access to the treatments that they need from the point of view of the use of antimicrobials. Next. As you can see, these are the key data. There's a big threat for world health, also for food safety and for the development, because antibiotics are not just used in human health, but also in animal health. In many products that many times we ingest, perhaps we're treated with some sort of antibiotics, and that will increase the possibility of developing resistance. This is something that affects anyone in different countries. Countries with more development and more access to antimicrobials most likely have a higher incidence, but in lower income countries as well, it is not very well quantified because they don't have a proper system, but clearly this is present everywhere. Antibiotics are used for many things, and many times it is possible that it is not necessary. So this has accelerated the resistance process. And unfortunately, there is each time a higher number of infections that are difficult to treat. A few years back in pediatrics, we were very happy because our patients could be managed with regular antibiotics. Now, with the progress that we've had in many fields, oncology, transplants, intensive care, neonatal intensive care, pediatric intensive care, we started to find antimicrobial resistance that is very similar to adults. And of course, this makes hospital stays be longer. This system is fundamental because we do not have enough beds. There is a higher medical cost, and unfortunately, it also has a higher mortality. So the impact for direct attention of patients in health services is extremely important. Next, please. And you can see it in 2050. It seems that it's very far away, but we're just around the corner from this time. And for that time, we calculate that continuing as we are, infections because of resistant germs will surpass the deaths from cancer. And of course, the human victims, 10 million deaths per year for 2050, a high cost. This is data from United States, where you can see that this number is shocking, but it has global impact, and it can reduce from the GDP in significant numbers as well. It's 3.5%, and the global cost of all of this can surpass $100 billion. Next, please. And what can happen in our region? This is the estimated annual deaths that can be attributed to antimicrobial resistance for 2050. We can see in the different regions how they will be impacted in different ways. Towards Africa, it's regions that can have a big problem. Latin America, of course, North America, they're not exempt from having deaths by then that can be attributed to antimicrobial resistance. And if we already know this, then clearly the most important thing is to take actions to avoid this, which is a projection, can actually become a reality next. There is data, as I was mentioning before, in children. It is calculated that 38% of children who live in different cities of Latin America carry bacteria that is resistant to colistin, which is a last line antibiotic, where two out of three children with meningitis and neonatal sepsis is caused by resistant bacteria. Europe does not escape this. 30% of resistant infections in patients below the age of 5. Also in Asian regions, 90% of newborns have sepsis in the intensive care unit because of bacteria that is resistant. And of course, also amongst these germs, we have Escherichia coli, which is one of the most common in these types of germs, and it has a concerning level. Next. This is a very interesting publication that came out this year. These are the death rates for all ages that can be attributed to AMR per region. And even though it's true, the region of Latin America and the Caribbean, which is like in third place, we're still not reaching the numbers, for example, of Europe or other regions where it's much higher. We have seen that association with resistance and also deaths that can be attributed by then to AMR. Next, please. Many of these infections, world deaths that can be attributed to infectious syndromes. Many of these infections are in upper tract respiratory infections, and with the pandemic, this has really increased significantly. So the association to resistance of these deaths is pretty high, surpassing 1,500, 1,500,000 people, and it also attributable to resistance, a very high number, with regards to the respiratory tract infections, lower respiratory tract infection, but also intra-abdominal sepsis and urinary tract infections, skin, central nervous system at a lower degree, but many times deaths can be associated to multi-resistance. Next. And this is what the World Health Organization has been mentioning for many years, which is the cursed dozen, and which are the germs that should be prioritized so that we can have antibiotics that can be facilitated to most people, that of course, in some cases, vaccines, as fortunately already exist. For some of these, we still don't have it, Streptococcus pneumonia and others, but we see that it's germs that are very much day-to-day in our practice of our everyday. So special attention to tuberculosis, which is a important case of death and mortality in many of the low and middle income countries. And of course, diseases associated to sexual transmission, as gonorrhea, that is also being multi-resistant. Next. And this has been what has happened since 1920 until the year 2000, where the acceleration in the production of antibiotics has been decreasing. We have some time in which new families other than the traditionals have not been emerging. And when we have a new antibiotic, and quotation marks new, it's usually a modification of the molecule of families that we already had before. And it is calculated that if today we have a new antibiotic, after having gone through the control clinical trials, most likely 10% of that population, that meta population, will have an infectious agent that is resistant to that new antibiotic. Of course, there have been many vaccines. I think this is the dupla that we have to keep stimulating: vaccines, new antibiotics, properly used antibiotics to be able to control the problem of resistance. But the new antibiotics, as you can see, have not been what is predominant in our market. Next. And maybe you see this in a much clearer way. Both antibiotics and vaccines have to be allies against antimicrobial resistance. But if we observe the decades of the 50s and the 60s was very important in the production of antibiotics. And then in the next few years, not so much. It was less the products that were developed, but there was an important number of vaccines that were licensed, not just to use in children, but also in adults. Next. And what's happening? Well, obviously, we have a need of innovative antibiotics. However, we also need laboratory techniques in all the countries that allow to identify infectious agents. And what we're mentioning here, it's not because they don't exist, but because they're not available for all countries, especially not for those of low resources. The availability in Latin America and the Caribbean many times is very limited. Not all countries, for example, Costa Rica has a social security system where this reimbursement system does not exist, but there are other countries that have a different system. So the availability and access are limited to that type of reimbursement for health institutions and hospitals. The Next, please. So this is a chart about the possible interventions implemented for COVID-19 that can have an impact on antimicrobial resistance. Of course, there is a positive impact and a negative impact. Between the positive impact, we might say that people took care of each other again from the point of view of hand hygiene, respiratory hygiene, physical distancing, when there were clean spaces. However, trips were also decreased. If we were not in the pandemic, most likely we would be meeting in person. The negative impact was that we did increase the susceptibility to bacteria and to anti-fungi as well. There was an important impact in the health systems, and there were a lot of factors related to management of COVID-19 that made patients increase the exposure to broad-spectrum antibiotics. And as I previously mentioned, the use of biocides at an environmental level also altered the ecosystems and potentialized the appearance of possible resistant bacteria. Next. The resistance to management, obviously, there is a need of public policies that have to promote many changes. The global strategy has to include several actions where in the diagnosis, and we could explain antibiotics and microbiome, that is extremely important, have to be strategic allies for the combat of antimicrobial resistance. And this is the impact in the activities of COVID-19 in the antimicrobial resistance activities, stewardship activities. In red, we have the negative, and in blue, we have the positive impact. But the biggest number of this slide, the biggest part of this slide, what I would like to emphasize is that the stewardship activities of the programs of optimizing antimicrobials was affected in, for example, consulting with infectology patients, the surveillance of antimicrobial use, the education and training was also affected. There was an effect in the prescription of these medications, and clearly this could alter in the next few years the problem of resistance. Next, please. And this is the summary of the COVID impact and the appearance and spread of antimicrobial resistance. As you can see, there was an emergence of resistant germs. There was a dissemination and spread of these germs and an overall world impact of what happened. And I would like to insist on this aspect. Not just was it human health what was impacted in terms of antimicrobial resistance, but also animal health, and very importantly so, environment health, and of course, public health is made up of a series of determinants that include these three scenarios. Next. This is the summary of the challenges and opportunities that we have. And I think that we have a lot of opportunities to change. We have learned a lot, the development of many laboratory techniques that were implemented for the time of COVID-19 that we're still experiencing. This is not over yet. And it made us see that we can join efforts and have new diagnoses that make clinical practice better. But also there's a lot of changes. There are a lot of needs of introducing all of these techniques in laboratories, and the economic situation maybe make it not feasible in many of the countries of our region. Next. Recommendations to combat antimicrobial resistance, of course. We were saying before that it's not just a matter of part of it. We need policies, we need to standardize procedures at a clinical level to recollect databases about the use of antimicrobials, that all of this should be done by the optimization programs. We need a lot of investigation to invest in investigation and big data. It's going to be fundamental. And of course, communication that we give not just to the health personnel, but also to our users, to the users of our services, so that they can understand that not every fever, not every gonorrhea has to be treated with an antibiotic. Next, please. And these are the basic points to be able to take on antimicrobial resistance. They are called the 9 steps to manage antimicrobial resistance, where the public commitment is fundamental. Health and hygiene is as well as antibiotic and agriculture and the environment used rationally. The timely use of vaccines, not just for the pediatric population, but also for adults. Surveillance has to be fundamental as well. Fast diagnosis, we can have through different techniques, laboratory techniques, we can have the identification of that bacteria in 2 or 3 hours. We don't have the susceptibility test, but at least we know that there is an infectious agent, a bacteria agent, or that we have an infectious viral agent. Therefore, we do not need the antibiotic. Human capital training. This is something very important because most likely you read how the pandemic has made many health staff have quit their clinical activities, and many of those that are being trained do not want to go beyond in their specialties, but just quickly go out and work and that's it. So there's a reduction in the interest of the population, the student population, in studying health-related sciences. The development of new antibiotics, we already talked about this. Hopefully, pharmaceutical companies will invest once again in the development of new molecules, and we have to get global innovation funds. If we should come together in something, the pandemic taught us that a global threat also requires global solutions. And in those global solutions, we have the investment and innovation that should be very similar for regions that speak the same language and that eventually could agree. Next. And this phrase, saving antibiotics so that antibiotics can save lives. We have to keep recognizing that the misuse and the excessive use has mitigated the positive impact that antibiotics have. And we need to be more intelligent. And of course, how do we implement and how are we doing the monitoring of the antibiotic? It's not just about prescribing an antibiotic just because. We have to think really well about what we're doing, what we're giving, and what is the timely moment. And of course, from the clinical point of view, there have been a lot of guidelines issued to reduce those times in which we're giving antibiotics that are not necessary. Next. Well, I would just like to thank you. This was my final slide. I would like to thank you for your attention. And here's my contact information on social media. It has been a pleasure to share with you. Thank you. Well, thank you very much, Dr. Avila, for your intervention. And it is worth it to highlight your observation about the impact of antimicrobial resistance in medical attention for patients. That not only affects the outcomes and mortality, but also the costs of the attention and, of course, about the lack of options or access to treatment for some of the most severe infections. Well, we continue now with Dr. Javier Guzman. Dr. Guzman is the Director of Health Policies in the Center for the Global Development in Washington, D.C. He was a technical director of the Program of Medication Technologies and Services in the pharmaceutical industry, funded by USAID and Management Sciences for Health. And he had several positions in the Colombian government from 2013 to 2018, including Deputy Director of the Technology Assessment Agency, Director of Medicine and Technology and Health Ministry, and General Director of the National Institute of Medicine and Food Surveillance Institute. So go ahead, Dr. Guzman. Hello, Mariana. Thank you very much for the invitation. It is a pleasure to be here with you. I will talk a little bit about the problem that we have in the market in terms of the development of new antimicrobials. And what should we do or what can we do to mitigate this? Basically, this problem in the market means that if we leave things how they are, then we see the situation that Dr. Avila described, in which there are no new antibiotics available for the use in hospitals. Next, please. First, I would like to emphasize something that she mentioned, which is one above, globally speaking, of causes such as AIDS, tuberculosis. And if we look at where people are dying from AMR, the deaths mainly happen in low income level countries, more or less almost 90% of deaths. You can see the chart on the right, die in low income level countries. Additionally, if we look at just children who die from AMR, and 99% are located in low income countries, which makes AMR countries like Latin America and the Caribbean. And we have a system of development of new medications that does not work. And it doesn't work because of three main reasons. One, because the incentives that we have to develop new molecules does not work if we cannot sell the product, or if we cannot sell the product at prices that allow to the return of the investment. And it is a system in which basically we ask the industry to develop a product, but we ask the countries to not use the product. And our colleague was talking about what we call stewardship in English, or in Spanish, the PROA. But basically, ask the industry to develop products, to then ask doctors in the different countries to not use the product, creates a problem flaw that shows us that associating we don't want more antibiotics to be sold indiscriminately, then basically what we're doing is reducing the potential of income that the industry has when they develop new antibiotics. And at the same time, what we see globally speaking is that there still is a lack of access in terms of antibiotics in many countries. So we have a system that, one, does not develop antibiotics, two, associates the return of the investment with sales volumes, and third, does not guarantee access of new molecules once they're developed, and doesn't even guarantee the access of existing molecules. That is why the problem that we have is in terms of design of how we compare an investment in antibiotics with an investment in medications that are much more commercial, like cancer, or like these nervous system viable, and so that the industry really considers this option, or the developers consider this option as a viable option. And there are two main mechanisms. On one side, we have the mechanisms that are determined as subsidies or push, which basically what they do is they fund the supplies or reduce the cost of those supplies. And amongst that, we have, for example, the investments that are given to in universities, public-private investments in antimicrobial resistance. We have one that is called GARD-P, and another one that is based in Geneva that basically funds researchers, gives money to researchers to perform their research and their development, reducing the costs. Of course, we also have tax benefits where so the declaration in the UN of 2016, a declaration for the first time that all the countries in the UN accept the importance of antimicrobial resistance. There are more mechanisms, funding mechanisms for subsidies to these research and development costs. But it is clear, and there's an agreement, that it is not enough. Just with subsidy mechanisms, we will not be able to have the number of antibiotics that we need. That's when we talk about a new innovative funding mechanism that is called pull. And pull basically is like, well, pulling that investment, basically promising or determining an increase of income once the development materializes. So that basically money for whoever develops medication A or vaccine B. A clear example has been the advanced market commitment, or the payment commitment that went around with the pneumococcus vaccine, but that also was used in the development of vaccines of COVID-19, where many countries of high income said, I will buy and I will pay this for this product that you develop. And in this case, what we're talking about is that we determine an amount given for a medication that complies with some special characteristics that are given in a product profile that we need. I think we won't have the access that we need, and this is concerning. That's why there are measures that have to be taken. There has been success in subsidy measures, but there hasn't been success in measures of creating a market that pays for the investment in a competitive way in terms of different areas of potential investment. Next, please. But we're going to go into that category of the incentives of creating that market. And in our institution, in the Center of Global Development, we did a systematic review of which were those possible incentives, and it is published on our website. We have a work group, a big work group, working in antimicrobial resistance, and basically there were two types of were incentives that did not remove that union between, or that link between volume and cost. On that clearly is, these are not the preferred. There can be a market, but it can bring the cost or the adverse effect of increasing the consumption of antibiotics in an unmeasured way. And these are the three examples that are mentioned. But I would like to emphasize on the second possibility next, please. Because this second possibility are mechanisms that where there is no correlation, there is no association between the price that is paid for that antibiotic and the use of that antibiotic, the volume of use of that antibiotic. Use of antibiotics in an inadequate manner, and to not depend on how much the antibiotic will be used. We know that antibiotics, we want to have them like as a reservation. We want to have them in case of needing them. We want to have them once we maybe find bacteria that are not susceptible to the first or second line. And in that sense, it is important that you go to the classification of antibiotics from the WHO called AWARE, which classifies them in three types of antibiotics: those that can be accessed, that are accessed, those that have to be carefully reviewed, and those that are reserved. But the point here is that those models that do not associate volume with price for those that have the make like antibiotics with A, B, and C characteristics that happen, for example, in the vaccine with pneumococcus. But like we said, we are talking about a very high amount, an amount that very few countries in the world are willing to pay in the tax situation that currently exists. but there are other models. For example, we have the subscription models, and we're going to talk about it. And in those subscription models where there is already an implementation in the United Kingdom, and there was an interesting proposal in the US, and a law that is called the Pasteur Act. And we tell the pharmaceutical industry, we give you the certainty, we give you the guarantee of an income in the next 10 years for a fixed amount. And in return, you have the medication that I had. Not just because we use it more will the industry will get more. The price is defined before the process that is the period that is being covered, and it allows total control of when and where that antibiotic is used. Next, please. These were the two examples that I was giving you. The first about the pneumococcus vaccines. The second is many of the legislations that exist in terms of incentives for orphan diseases in many countries. There is an extension of the patent times for these molecules that come in from orphan diseases. There are examples that have been given. They haven't been implemented in new antibiotics and antimicrobial resistance. Next, please. Possibility of doing different mechanisms. This is an only payer. The health system covers the entire population of England. They launched the pilot in 2020, 2 years ago, and they say, we're going to give you £10,000 for 10 years, £10 million for 10 years for 2 medications. And this is a way of not bringing together price with volume and funding innovation through an incentive that is given at the end of the development process. These medications, interestingly so, and here we have a point that I believe is important to highlight, includes an assessment that is not given just in the clinical individual benefit, because here the antimicrobials externalities that the use of antibiotics have. So positive and negative antimicrobials have benefits like allowing to have surgeries, that there is no long-term resistance, no pressure for the development of resistance. So these are externalities that are positive that we have in that value quantification, but at the same time, there are negative externalities. Each time that I use an antibiotic for myself, I am increasing the possibility of that bacteria developing resistance to that antibiotic. The point here is that the evaluation mechanisms of cost and benefit many times only consider that individual value and that individual cost. So we have to improve at a global level of how we determine that for society. I think that Diego will talk about this later. Next, please. So definitely, subsidy mechanisms, as I mentioned, there have been some examples of design and implementation of mechanisms of pull or trying to recreate the market in Latin America. There are other interesting examples, for example, in Sweden, but it's minimum. There is still not a broad implementation of this type of mechanism, which leads us to thinking of which is the best way to implement differential payment methods in middle and lower income countries. So what can our region do to, on one side, not associate price to volume, and the other side guarantee access when we need to guarantee access, and on the other side reduce guaranteeing the access to the necessary antibiotics of first and second line. Next, please. We think that the way to look at this problem is considering that there are 3 legs of a chair that have to be included in any conversation. The legs on one side, we have innovation. There has to be enough funding for innovation, but that innovation has to have access and it has to have particular conditions to be able to optimize the use of any medication. It can't be just a use associated to more volumes or use associated to inadequate use. The second part of the second leg has to do with the optimization mechanisms or stewardship. We want more when needed to reduce the pressure of antimicrobial resistance in the long term. And finally, we want access. We want access that allows the adequate use of antibiotics of all those lines according to necessary. The way in which we think this can happen is through great global commitment, that great global commitment where the countries of higher income are clear in their responsibilities of increasing the market size, that they're clear in the need of supplying access to low and middle income countries. But on the other side, for the low and middle income countries, as the payment capacity increases, there has to be a contribution to innovation. There clearly has to be optimized that is developed for the use, not just in the private sector, but the use for the entire population. So this great commitment is an idea that we're developing at a detailed level of which are the responsibilities, which are the rights of the different countries. But we definitely think that there has to be a change in how those medications are paid. There has to be a change in how innovation is funded, and there has to be a great change in mechanisms and actions that are immediate that allow to reduce the negative impact that antimicrobial resistance already has. We were talking about 1,200,000 deaths globally and 5 million who die with infections that are resistant a little bit about the details. Thank you. Well, thank you very much, Dr. Guzman, for your intervention and for sharing these possible solutions to the market flaw that limits the development and access to these antibiotics. Okay, now we have Dr. Diego Guarin. Dr. Guarin is the Regional Director for Market Access for Latin America and MCD. He has been the head of market access teams and health-related results in the main biopharmaceutical companies at a global level since 2018. Dr. Guarin has been a key contributor and pioneer for the development of pharmacoeconomy research and results in health in Latin America since 2017. Also, he is a physician with Masters in Public Health of London School of Hygiene and Tropical Medicine and Public Policy Management for Health Economy from the London School of Economics and Pharmacoeconomy from the University Pompeu Fabra. So I hand it over to Dr. Guarin. Welcome. Thank you, Mariana, and well, thank you everyone for being here. The speakers, I have 2 challenges. One, I am going after Maria Luisa and Javier, and I have less than 5 minutes to be able to give space to Dr. Valdo. So I will try to be a little bit fast this presentation. So I ask you all to, despite the fact that we are here until 11, if you can stay here a little bit longer to be able to ask a few more questions. Next, please. And next, please. So please, microbial stewardship. 2, we need to think about how do we include incentives to assure equitable access between high-income countries and low-level countries, and the middle and lower income countries like Latin America, people who are in the public and private sector. So 3rd, we need to test, because like Javier is saying, we don't have $1 million for companies to register the medication. We know that 70% of the population is in different conditions, and this is important from the global point of view, from the equitable action and how we manage antimicrobial resistance. Next, please. The problem, as Javier was saying, over here, in which there were 250,000 investment from the US government for 6 years to develop a medication, and in effect in 2018 they were able to get approval from FDA, and then there was a problem because they went bankrupt because there was no demand, because like Javier was saying, the antibiotics are essential goods that are priced, are precious, are very few. And following the indications of the WHO, when you see in 2021, the chart that you see in the middle, 7 out of 12 medications that have been approved were classified as reserve. Only the medications, only 20% were new therapeutical class. The others were others that already existed as a variation. So this generates an impact in all the decisions of research and development. On the right hand, I'm showing you the reports are being developed by startups. Big companies, big pharmaceuticals, very little of them, very few of them continue in medications. And the reason is because there is still, we're missing that return from the investments. And at the bottom, in startups, if we only look at startups, in yellow we see oncology, in red we see antibiotic medication. The gap is very big in terms of the amount. The gap is huge in terms of investment. And just to give you a piece of information, in 2021, more than 260 medications for COVID are being developed, and more than 158 medications for breast cancer only. So compare that with the 7 or 12 medications that were approved in antibiotics. Next, please. The problem and the solution has to combine funding, as Javier is mentioning, but also change, like we did in some countries, where we can give some sort of contribution. So here what we're talking about is the valley of death. I'm able, after many years, to have a medication. I pass it on to regulatory approval, and then nobody uses it, because that's what we're looking for, a rational use of medication. And what happens? I go broke, and companies have incentives. So the solution can be to have those payments that are not linked to volume. So to have that bridge between what was funding the reform, so that it can be sustainable and that there can be new elements that we require. Next, please. Would be $11 million for 10 years that would be paid to these companies who develop antibiotics to guarantee a return, a financial return, and remove that connection of antibiotics with the return. And sorry, 2 things, Germany and France we have evaluation agencies in Latin America. What would happen if an evaluation agency in Latin America said, okay, a new antibiotic is going to have some value. I'm going to recognize that it has a therapeutic value that is additional, and I'm willing to pay a price different from the antibiotic that exists today in the market, because that's a problem with the development of antibiotics. I'm not showing that I'm better. I'm showing that I have a certain profile versus some bacteria that are resistant that, in fact, it's hard to be able to do this. Next, please. Thank you. That we think might be useful in antibiotics to be able to pay for that type of technology. I'm not sure if you can all vote, but okay, I have one vote. Let's give you a couple more seconds. I'm going to allow you to read the definitions, but in general, one, I can mark if an infection, it has antimicrobial resistance and give it a Z code, which is something that we do in US. Another thing is that I can mark the technology. It's a new antibiotic, so I'm going to write, I'm going to give a code to that antibiotic. So I paid the differential amount per disease or per antibiotic, and I can remove that connection, like, and I can have a payment model like in Sweden, and it works in countries in the public sector. Or I can have and TAP. So we did the same thing later, and we tested it in 4 countries in Latin America. Next, please. And basically what we did was test the models that we have, 1 in subscription, 3 models of subscription, DRG carve-out, and NTAP. So I don't know if we already went to the next slide, but basically in summary, and you will be able to see this in detail later, portfolios, what's working in Latin America, and it's what's working in the private sector. So when we go to the public sector, it's much more difficult, but the solution could be to look for something like a subscription, to look for something like a separate payment, and the DRG, like the business between the hospital and the payer. Next, and I think that with this, we need to change the way in which we pay. And these reports that you see here, please read them, because I think that they have interesting ideas to keep moving forward with this. And with this, I hand it back to you, Mariana, so that we can continue. Okay, thank you very much, Dr. Guarin. Yes, we have 25 more minutes, so we still have a little bit of time. Dr. Waldo Belloso will be with us now. We have him from Buenos Aires, and Dr. Belloso is a specialist physician in infectious diseases and clinical pharmacology from the Buenos Aires University, and he has a PhD in statistics for health sciences and direction of incubators, accelerators for the development of entrepreneurship. National Sub-Administrator of the National Administration of Food and Technology in Argentina, Food Technology and Medication. I remind you that you can send us any questions through the chat box for the Q&A session. Welcome, Dr. Belloso. Thank you very much, Mariana. Thank you to the previous presenters who have made this work very easy, because I don't have much more to add, but trying to give a complementary view of what has already been mentioned today. Next, please. Since a while back, I decided to present my disclosures this way, not just in the traditional way with the possible context where I dedicate my time, and where do I get my general income from. I think that this is the best way that whoever is receiving the message can understand from where. Next, please. And in the call that the foundation made to me, they asked me to take on these topics, the initial considerations that were necessary for the increase of access to innovative antibiotics. So to think at the beginning, before presenting the possible solution, some sort of consideration on the new law of prevention and control of antimicrobial resistance that is being discussed in Argentina, that has already been issued, but we still need the regulation per se. The barriers in Argentina for the implementation of public incentives that has already been talked about by Javier and Diego, and how the incentives of general considerations. Some have already been shown here, but I want to give you perhaps a complementary view. I think that the first point is, and I do it eminently as an autocritic, many of us, I've done it as well, have presented this data of what would happen or what will happen for 2050. I think that this is like an invitation so that none of the transactions will have great impact, like some sort of a prophecy. So I think that even though the data are much more difficult to obtain, it would be interesting to see what would be the potential impact of being able to carry out the actions that we are promoting in terms of the reduction of the mortality and morbidity produced by antimicrobial resistance towards the year 2050. There is little space so that we can have interest in acting. Next. The second point is to understand or to think and discuss, and it has already been something that I have talked about briefly here, is that when we talk about innovative antibiotics, what are we really talking about? So from all of the last developments of antibiotics that have happened since 2017 on, there is only in the columns on the right that are highlighted 2 antibiotics that belong to new types, no antibiotic that has a very different target, and only 1 antibiotic that acts differently than the ones before. So they would be innovative in terms of the exit of the market, but not necessarily innovative in terms of their action mechanism. This one, please. The other consideration is that when we talk about new antibiotics or innovative antibiotics, we have to consider that the new antibiotics are supplies that are necessarily interchangeable, because as you can see here, not all new antibiotics act in terms of the antimicrobial resistance that are prevalent and that are the main concern when it comes to treating our patients. So it's not the same to have an antibiotic in terms of prices as another, because maybe we need one at some point and we need another one at a different point. Next. And I agree with what Javier was mentioning in terms of an economic problem that is very significant in terms of the generation of the market. Now, I want to note or the amounts that we would want to have them. There is not just a problem in the market that has been very well taken on by Javier and Diego, but also there is a great difficulty when identifying new targets. And this is what is reflected in what we were recently talking about. There is a problem in terms of identification of new therapeutic elements, and this has led to the increase, the progressive increase of what is called non-traditional mechanism antibiotics, between amongst which we can consider modifications of virus, vaccines, immunomodulators, biological medications, and even so, modificators of the microbiota. Next. So these are new players that are coming, or medications of non-traditional action mechanisms. So there is, additional to the economic problem, a scientific program, scientifically based problem with the difficulty in terms of the development. Next. So in fact, this is a list, most likely insufficient or preliminary, of the amount of new molecules with this type of untraditional mechanisms that are being developed with different degrees of development currently. Next. The other point that has already been mentioned by Maria Luisa is that we have, from what was stated by the WHO, the list of priority germs that we see it. The list that has already been mentioned of the priority antibiotics. Next. Next. And for each one of these antibiotics, of these germs, there are difficulties that have to be overcome for the development of new molecules. Next, please. Next, please. And an important point that we have to consider is that we not only have to consider the list of the 12 problematic germs that have been identified, but for each one of the problem germs, you can see that we all use mechanisms more than particular germs. You can see that nowadays, the main problem that we face from the point of view of treatment of patients that are immunocompromised or more severely sick are the carbophenamases, the enzymes that destroy the carbapenems. And not just do we have just one type of carbophenamases, not only do we have KPC, which is the traditional or the one that we normally refer to, but each time with more importance, are we increasing the prevalence of other types of carbophenamases, like, for example, the MBLs or OXAs, or we have seen from the pandemic or levered by the pandemic, the combination of resistance mechanisms to carbophenamases. So the bacteria that are double producers of carbon problem. Next, please. Next. That's why I think that more frequently so we're going to be talking about resistance mechanisms more than the identification of germs per species. Next. So this way we can see that the distribution and prevalence of the different types of priority resistance mechanisms varies according to the geographic distribution. And it's not the same thing to have the prevalence of KPC or MLB in Costa Rica as in Brazil, or in Brazil as in Chile. So there is geographic variation, not only at a country level, but at a region level within each one of the countries, as we will now see. For example, so it's another point that we have to consider. The prevalence of carbophenamases varies in time. So look at what happened in 2017. Practically the entire country was red because the carbophenamases that were more prevalent were KPC. This in 2019 has already varied because there are provinces where MPL, but also NDM, start being more prevalent. And in some provinces, we can see the coexistence of resistance mechanism. And this variation in time, like I said, has been levered and increased because of the presence of COVID. Let's click, please. It's animated. Next. And here you have in the Argentina. Users, the microbiologists calculate that I think that we have the times of the period of appearance of resistance for 10 years next. Therefore, I would say that we have to consider this concept of how to take on resistance as a mobile blank or a moving blank, where there is a triangle in which on one hand we have prejudices that are the most rigid, always the more rigid are our prejudice. And on the variability side, we have most likely the solutions. The available antibiotics are relatively limited, as we have already mentioned. The priority germs are very variable. So this is a general concept in terms of how to take on this problem. Next, in terms of the law of prevention of antimicrobial resistance, the considerations that we can make, like Maria Luisa already said, this topic is being taken on in different countries of the region. In Argentina, we have had the possibility to see it in a law that, like I said, already has to be regulated. I think that the law is falling short in many aspects, but as general considerations, I would say that it is a very important law. First of all, because it visibilizes the antimicrobial resistance because of priority, as something that is priority. Second, because according to what we could show here as the pyramid of Kelsen, it's not this order law. So it is a law that has to be directly applied to the entire country. And third, because the law has been approved unanimously. So there no longer is a problem in terms of other elements behind this problematic. The other interesting point of the law is that it promotes the adequate use of antimicrobials and the measure for the intra-hospital measures. There is no possibility of doing proper stewardship if we don't coordinate the efforts with the prevention of the infections. Here, it is very important that all the control measures, especially of intra-hospital infections of bacteremia associated to catheters, of pneumonia associated to respirators, and appearance or the appearance of new antimicrobial bacteria. Next. Also, the law promotes the generation and the permanence of the national condition for the struggle against antimicrobial resistance, CONAC. Those responsible for the antimicrobial use for human use and for environment use and animal use all live together. Next. Also, another one of the positive points of the law is that it promotes not just the selling under archived cell or filed cell, but the adaptation of the presentation of antimicrobials to the recommended duration of treatment so that we don't have antibiotics at home of each one of us. Next. And to complement what has already been expressed by Diego especially, and Javier, which would be the barriers that we see for the implementation of pull incentives here in our country, for example. Next. It's already clear that the push mechanisms are interesting, but are not enough. And the pull mechanisms, where we give priority support to medications that have already been developed, that have some sort of characteristics that make them interesting. And we might identify as priority those agreements based on financials where we remove the connection between payment and sales volume, like has already been mentioned, like for example, subscription mechanisms or portfolio mechanisms, and those mechanisms of agreements based on performance or based on results. And we have some examples in our country and in the region of agreements based on results. However, our agreements based on results are difficult to carry out. And especially, I think that they're difficult in the area of antimicrobials. Next. Why the risk-based agreements or the agreements based on performance are difficult to implement? First of all, because of the fragmentation of the health system, which is very important in our country and also in many countries of the region, with which it's difficult to find just one speaker to be able to dictate on the other side of the counter the negotiations with the producer. The other point is that we need data, and it is very difficult that we produce additional data than what the doctors and the health systems already have to be producing normally. So the outcome data are difficult to have to be able to do concrete analysis about the performance of a product in particular, specifically when it's about antibiotics. And the other point is that even when there's data, in the case of antimicrobials use, in the case of limited use, and in the case where there's possibility of a fatal outcome, there's many paths that lead to the same outcome. And the fatal outcomes are in general multifactorial. So it's very difficult to discriminate when an outcome has been a product of inadequate use of an antimicrobial than when the antimicrobial has been properly used, but however, the outcome has happened differently. Next. So reaffirming what was mentioned before, which would be the measures that could be taken in pull type that can not just improve access to antibiotics, but fundamentally combat at the same time. Next. Okay, as we said, the best antimicrobial is the antibiotic is the best that is not used. We need the development of antibiotics so that they're available to be used only in those situations in which it is absolutely necessary, because each time that we use an antibiotic, we are promoting resistance. This way, therefore, the only thing that we can do to reduce the prevalence of resistance is to reduce the inadequate use of antimicrobials. Next. And in that context, the mechanisms that disconnect payment to sales volume, I believe, are the most adequate for the use within the criteria of the use of antimicrobials in general. It has already been mentioned by Diego that the ideal situation would be perhaps to aim towards a subscription system, as we already know, especially with the great partner of the pandemic of many people, but to have everything available on the shelves to be able to use it only when we consider that it is necessary. Next. The point, as I was saying before, in our fragmented system is how to make this viable, how to make there be a centralized system, a centralized agreement to use the antibiotic only when it is absolutely necessary and correctly, that corresponds to the real needs of that moment and that patient. Next. and lights and shadows of science in the pandemic. I think that there are a lot of shadows that we have to learn to not repeat from the past, but within what we can consider as lights from what we have seen within the pandemic, some sanitary decision making faster than usual with proper support and a proper acceleration of processes have been seen in some cases. Amongst them, in some of our countries, and mine, for example, we have made decisions of centralizing the purchasing of some medication from the health ministry and to distribute it, even in a fragmented system, to distribute it in a consensuated manner previously, but restricted from a central control system. Next. I think that there are things that we can have been seen in the pandemic. One is the metacognition. We have wondered each time more frequently, why do we do what we do? Or how do we do things so that they can have a better result? Also, there has been a lot of desire to collaborate. The possibilities for collaboration between different institutions, between government and user, collaboration between public and private have been levered in the pandemic, and we shouldn't lose that increase. Perseverance, I think that has also been seen. And well, even though the journey is long ahead of us to be able to improve the perspective towards 2050, I think that we have to persevere in this. And the participation, I think that as I haven't really seen this, but many people have wanted to be a path to be able to move forward in the adequate use of antimicrobials so that they are available whenever necessary, and that it also contributes to our struggle against resistance. Next. Thank you very much for the invitation and for your attention. Perfect. Thank you very much, Dr. Belloso, for your intervention. It was very interesting. And we are reaching the end of our session. We have time perhaps for one or two of the questions. I saw that our experts answered many of the questions through the chat box. However, there is a question which is these new strategies and to my teams. Wouldn't this be a possibility for managing it? Whoever wishes to answer. If you allow me, yes, of course. I think we lost Maria Luisa. So while she reconnects, if I may comment on this briefly, I agree with that idea. In fact, I didn't mention this, but in the Argentinian law, we also consider new possibilities to favor the investigations in antibiotics. And I believe that we have to take the example of vaccines and also take advantage of the so a collaboration, public and private collaboration, that goes out a little bit of the standard reference of clinical trials with sponsorship from the industry to be able to have faster studies that give pragmatic results that can be implemented faster. Okay, perfect. So if you allow me to say something, I think when we think about vaccines, we have to vaccinate people to against pneumonia, because that's the best way to prevent infections, prevent resistance and to not have infections. So we have to have vaccines and look for mechanisms such as vaccines for antibiotics. And I'm not talking just about new antibiotics. We don't have generic antibiotics. Many times the physician, especially in the public sector, maybe has imipenem of broad spectrum. So that's the point. It's not even the medication. It's not about the cost of the medication. Okay, understood. Yes, it's not one or the other. One final question, and we will close the session. Is there any incentive, like we said in Colombia, like having something easily available and that it can be implemented at the short term as a solution? I answered through the chat. I think that number one is let's mark the infection, or let's mark the antibiotic, and we recognize a higher payment. That's an option that can be done. That does not require Congress or the government. Or second, let's mark, and if we do HTA, like in Colombia. There's a final question. How can the effective diagnosis help in this stewardship of antibiotics? It is fundamental. If we don't have the effective element, it most likely will be using antibiotics inadequately. That is why, in this perspective, multidisciplinary aspect that we take on this topic with, it is very important to have the contribution from microbiologists. We did a survey in our country, and 72% of the laboratories have a possibility to access some sort of fast diagnosis, whether it's low complexity, but some sort of fast diagnosis. So it is Mariana, if you will allow me first, I apologize. Something happened and the Zoom kicked me out, but I'm here again. And what I wanted to mention when I was going to speak is that most likely, and it was mentioned with vaccines, Latin American can have something like a rotating antibiotic fund precisely for those difficult cases. At a Central America level, there is a regulation to avoid joint purchase of some things. For example, it was applied for purchasing medications against HIV and also some molecular antibiotics for respiratory viruses. So perhaps it's a good way a good strategy to be able to manage antibiotics properly. Well, thank you very much. Okay, well, just to close, since we are antimicrobial resistance clearly is a big threat to health. Then 1/4 of infections are antimicrobial resistant, the antibiotics that are generally prescribed in the first line, and these rates can increase up to 50% or more in the next decades. For this reason, timely, secure, and stable access to antibiotics will be essential to mitigate future pandemics of infectious diseases and the antimicrobial resistance in the future. So as we saw from the presentations of our experts, the new and severe cases as a final resource treatment. So because of these lack of profit in terms of the investment and other barriers, the traditional forces of the market on themselves will not be enough to guarantee the commercial launch and the sustainability in the market of the new antimicrobials, as was mentioned by Drs. Guarin and Guzman. We see that pull incentives offer a method that, if it's introduced, could be a public policy solution that is viable for our region, through which these antimicrobials that are high value, or those that are used to treat infections in humans for which there are no other options, or there are few options, we can increase thank you all once again for being here with us today. Our panelists for the excellent interventions and perspectives that have been shared with us, and to MCD for sponsoring this important event. We will have a summary of the event that you will all be getting in your emails, and we will also communicate it through our social media. Thank you, everyone, and goodbye. Goodbye. Thank you very much. See you soon. Thank you.